lateral lead. That is an extensive anterior wall MI, okay, or the Widowmaker. Keep going too far. All right. So now let's look at strip number 8. So we will look at 2, 3, oh, sorry. Let's erase that. 2, 3, and AVF. Zoom in here. Lead 2, I'm isoelectric. Lead 3, difficult to tell there, but it does appear that it would be elevated. So if I come back to the segment right before my QRS complex, if I work my way back, I have a millimeter of elevation there, right? Between my J point or my ST segment and coming back, if I called that isoelectric, which I believe that it is. And I believe that it is because when I move forward from my J point, I'm sloping down to begin coming off a T wave, beginning my P wave, and then I'm going, my P wave's coming back down to isoelectric before it goes into my complex. So for this particular beat, I would find my J point or my ST segment, work backwards, because I believe that gives me the most clear picture, and I have a millimeter of elevation there. So I do have elevation in lead 3. Not much, but definitely some. Lead AVF. This one gives me, either one of these gives me an okay picture. But I'm going to come here and use my J point, work my way back, and I have, again, right at about a millimeter of elevation. Okay, and this one may give me a better picture, but right at about a millimeter of elevation. And that is very, very close. With just looking at this on the screen of an iPad, it is very difficult to tell, but that is close enough to me to call that elevation. They both look like they're at about a millimeter of elevation. So let's see here. 1 AVL, V5, V6. No elevation in 1, no elevation in AVL, no elevation in V5, no elevation in V6, 1 and V1 and V2, so our septal leads, no elevation. V3 and V4, our anterior leads, once again, no elevation. So I have elevation in 3 and AVF. Now, in this case, again, that elevation is really close to being a millimeter, and it's hard to tell. I'm zooming in the most that I can zoom in, right? But if you're in doubt, err on the side of caution, right? If I'm in the field and I have this strip in front of me and I'm going back and forth between, is this a STEMI, is it not a STEMI? I'm going to say it's a STEMI, right? I would rather err on the side of caution. I would rather be a patient advocate, notify the hospital, transmit my 12-lead EKG to the hospital to let them compare it to old 12-lead EKGs, get prepared to receive the patient and so forth, rather than, I don't think it's an elevation, so we'll just continue transport to the hospital and we'll ask them when we get there. Be proactive in that circumstance. Now, this is an inferior wall MI, so don't forget to do your right-sided 12-lead by moving V4, okay, and running it again to see if you have elevation. All right, 2, 3, AVF, definite elevation in all of these leads. 2, definitely more than a millimeter. 3, definitely more than a millimeter. AVF, definitely more than a millimeter. So right there I have an inferior wall MI. 1, AVL, V5, V6. So this, I'm glad this strip's in here because this gives you a good example of why I don't use the first beat. sometimes in most of these strips, the first beat has looked just fine, but there are times where that first beat can give you a false reading. And I believe it does that in V4, V5, and V6. But let's go back to lead 1. So lead 1, no elevation. There's actually some depression there. Lead AVL, there's some depression, which I'm not shocked about because I have elevation in leads 2, 3, and AVF. So when I see elevation leads 2, 3, and AVF, I can expect to see reciprocal changes in leads 1 and AVL, which I do. I see it right here. I have elevation in 2, 3 AVF. I have depression in 1 and AVL. We'll move to V5 and V6. There's no depression or elevation, so those are fine. V1 and V2, no elevation, some depression in V2. Definitely has some depression in V2, which that's fine. Not really gonna change our treatment. We might do another 12 lead and 10 minutes down the road, which we should be doing anyway with longer transports. We should be taking numerous 12 leads on the way to the hospital, even though we've already identified a STEMI, to see, is this thing progressing? Is this thing starting to include more fields, or is it staying isolated to the inferior leads or to the anterior leads? So we should be doing that anyway. Lead V3 and V4, no elevation in those leads. So I have elevation once again in leads 2, 3, and AVF, and I have reciprocal changes in 1 and AVL. Okay, so I have an inferior wall myocardial infarction with reciprocal changes in lead 1 and AVL. All right, so lead strip number 10 here. I'm going to zoom in. So this is not very good quality. Definitely has some artifact. Leads 2, 3, and AVF. I don't see, through all of the artifact, I don't see any elevation there. 1, AVL. Oh, sorry. And then we'll get over to V5 and V6. So lead 1, I don't see any elevation. AVL, I do not see any elevation. V5, no elevation, maybe some depression in V5. So probably some depression in V5. No depression or elevation in V6. I move to my septal leads, V1 and V2. Zoom in on these, see if I can get a better picture through all this artifact. And V1, I would say we are isoelectric. Again, it's hard to tell because of this artifact. This beat in particular, this is close to having some elevation. When we come up and call this the J point, if we drew a straight line over, which is hard to do with my finger, we might have a millimeter of elevation there. It's just really hard to tell with all the artifact. And we don't have a real good picture of the isoelectric line, so we'll keep an eye on that on V1. Keep it in the back of our heads as we move through. V2, it's going to be the same story. Don't really have anything great to go off of. I'd call this my J point here, which does not seem to be elevated in either direction if I go forward to the isoelectric line or backward. I don't see anything in V2 to say, yep, that's definite elevation. V3 and V4. V3, there's my J point. I don't think that's enough elevation to warrant anything. Let me go this one. There's my J point. I don't think that's enough elevation to warrant anything. V4, if anything, has a little bit of depression, and that looks consistent from two different beats there. So it looks normal sinus. There might have been some elevation in V1. I'm not sure what they're going to say about this one. ST segment elevation in V1 through V3. They're saying, I don't get that personally. I can't identify any definitive J point or ST segment. Again, in V1, we kind of picked up on a little bit there. V2, I don't think there's anything definitive enough to say that there's elevation. In V3, again, I don't think there's anything definitive enough to call it elevation. So I disagree with that interpretation. I would call that normal sinus at that point. 12 lead number 11. All right, so get my pencil here. Oh my gosh. Leads 2, 3, and AVF. Let's see. So looks like we're gonna have some. Lead 2 looks to be lead 2 could potentially have some elevation there. Lead 3, not a real great place to go off of, but either way, I would call that our ST segment or that our ST segment. Either way, there's definitely elevation regardless of which one we go off of there. Lead AVF again has this funky bass line, so it's pretty hard to find out what's isoelectric and what's not. And that's our last of. Okay. So with lead AVF, I'd say our J point is about right here, and you can tell where our QRS complex is coming up, and then has that junction there into our T wave. So I would say our segment is right there. As we work our way backwards, we might have a millimeter. Again, it's hard to tell with these 12 leads on a computer screen, as I'm sure it's going to be difficult to tell on the 12 leads in your handout. But we definitely have elevation in 3. We're close to having elevation in AVF. So I would go ahead and, again, err on the side of caution and call that an inferior wall MI. Leads 1, AVL, V5, V6. Might have looks like I have some depression in 1. Lead AVL, I definitely have some inverted T waves there. V5 has some depression, V6 has some depression. So I have reciprocal changes in my lateral leads, which definitely makes me lean towards AVF is elevated, right? So we know 3 is elevated. We're on the fence about AVF, but then I have these reciprocal changes in 1, AVL, V5, and V6 in my lateral leads. So that makes me think, okay, what I think may be elevation there in AVF is definitely elevation. So again, there's those reciprocal changes coming in to help me in thinking that this is an inferior wall MI. Septal lead 1 and septal lead 2, V1 and V2. No elevation in V1. Definitely have some depression in V2, V3 and V4. Depression in V3 and depression in V4. So at this point, we have elevation in leads 3, AVF with reciprocal changes in 1, AVL, V5, and V6. So I have an inferior wall MI. as seems to be the theme for these